Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to our Authors Podcast for JVRD. I'm Dr. Timothy Murray, Editor-in-Chief for the journal, and I'm joined today by our senior author, Dr. Sabin Dang, who is the Retina Institute in St. Louis, Missouri. We're going to discuss his paper, Economic Impact of Anti-Vascular Endothelial Growth Factor Prior Authorization Process from a Large Electronic Database. Welcome, Dr. Dang.
Thank you for having me.
It's a real pleasure. So I think we have all had the perception that prior authorization significantly impacts the ability to deliver quality, timely, personalized care to our patients. Can you take me through a little bit of your thought process with your team in developing the hypothesis and then how you investigated that for your manuscript?
Yeah, absolutely. I think you hit the nail right on the head. A universal theme talking to retina providers across the country, whether you're in academics or private practice, is the burden of prior authorization. Increasingly through our field, we've noted that administering vision-saving treatment is becoming more encumbered through a bureaucratic process of prior authorization. And anecdotally, we find that, hey, it seems like we never really get denials. So me and my co-authors, we got together and we said, hey, let's look at this on a large database. Let's really answer a couple of questions. One, is our anecdotal evidence actually true? Are the prior authorizations we're requesting uniformly getting approved? Further, let's try to actually quantify and establish what the burden of prior authorization is, but let's be cognizant of the overall financial impact to society, including what potential economic benefits may also be present from prior authorization. Put that together so we can get a very quantitative established view on what role prior authorization plays in American healthcare.
It was really interesting to me how universal that perception was that prior authorization was essentially never denied, right? That what it was is a stop that says no, and then our offices have to work their way through that process, which in many cases is quite onerous. And in that process, our patients are delayed.
I mean, that was one of the staggering statistics. I mean, first off, we should just emphasize that when a ophthalmologist or retina specialist specifically is asking for anti-VEGF injections, which again, we know will prevent blindness, we were told yes 97.7% of the time. I mean, right there is already an incredible statistic. So we're not asking for treatment inappropriately. The insurers are agreeing with us that our treatment is appropriate. But because of the prior authorization process, 97.9%, essentially 98% of the people who did get approvals had delays in their treatment. So universally, now the system is encumbered by all the processes you just mentioned. You and I are seeing patients. We say, hey, you need a treatment. We can prevent blindness. I can't help you today. I have to bring you back a different day just because I need to verify with the prior authorization with your insurance company. And we find the delays are not insignificant. We're talking about, in some cases, 5 days between authorization as a median and mean, with ranges substantially longer.
And one of the things that we've learned in our practice is that nicely targeted with our electronic medical record is the exact expected appointment date and then the patient's true appointment date. We have patients where they miss by 2 days and there's a significant decline in both anatomic and visual function. So we're setting our patients up potentially for permanent visual loss.
Absolutely. And unfortunately, that was one of the limitations that my authors and I identified in this trial. We couldn't really address the impact to quality of life from the loss of vision, from that delay in care. We were really only focused on the economic aspect. But on that side, as we're talking about those delays, one of the things that we're trying to introduce into literature and conceptually is it's not just the delay from a medical care standpoint, but let's look holistically. When we delay a patient's care, we are not telling just that patient, you have to come back. We're telling their caregiver, you have to take off work again. You know, the modern era is most of our patients who are getting treatment, are they themselves working? Their caregivers are working. You've taken two people out of the workforce unnecessarily to handle this administrative burden. All of that has major economic impacts. And as we're looking, it's like, yes, we are deeply concerned about the quality of care that the patients are receiving due to the delays. I hope to address those in future studies, but in this case, the employers that these patients work for and their caregivers work for sustain economic impacts. The patient, their caregivers sustain economic impacts. And as you alluded to, the minute that patient leaves, and my staff, your staff, we're all working to try to secure that prior authorization. And that's a substantial amount of time that our team members are spending just addressing these bureaucratic hurdles.
Yeah, it seems to me that there are so many hurdles in terms of the management of our patients where common sense would alter what we do. I love that in some offices you get seen on one day and injected on another. And if you need both eyes injected, you don't get them both injected on the same day. Often those have financial repercussions and drive the care. It seems to me that, the person to make the best decision should be the physician who is a retina specialist and the patient. And it seems like this placement of bureaucratic burden, I don't ever see it help my patients. I just see it be either neutral or harmful, in this case, harmful. And I know you and I both have patients that travel potentially long distances for care. So imagine when you look at a patient and they've driven for 2.5 hours, had an hour visit in your office, and you're looking at them saying, you're going to drive back and we'll get you scheduled when you're authorized. I can't even in good conscience feel that that's relevant to good medical care.
It really is a challenge. And so one of the things in our study, we're able to address some of that very specific things. So let's kind of get to the punchline.
Yes.
Every prior authorization is a $638 societal cost. That is to the patient, their caregiver, the medical provider, the employer of the patient and their caregiver. And we're modeling all the extras, including the extra technology needed to handle these prior authorizations. So we're looking at a modeling basis, $638 per prior authorization through a patient's lifetime. We're incurring an extra societal cost of $10,842. Now let's look at where the system is benefiting. The only area we were able to find a potential benefit was that insurance carriers were potentially saving about $27 per injection on average, because of, again, the widespread authorization. So they're saving just a few dollars, but that few dollars of savings is borne on the back of the entire US economy, who is sustaining those economic losses. So for their individual profit margins, it's helping for a few bucks, but it's costing us hundreds on the other end.
But I don't think people also appreciate how many intravitreal injections we perform in the US every year. So these small relative incremental costs are massive in terms of the economic impact, correct?
Absolutely. And I'm sure you've got patients like I do. They think they're going to be one and done, right? Like, oh, hey, one shot and I'll be good, right? And we have the unfortunate responsibility of explaining to them that this is chronic disease. You may need shots monthly for the rest of your life. There are patients who need that, have that high treatment burden. The great news I tell them is like, hey, 20 years ago, you would have gone blind. Thankfully, we have this technology and these medications to keep you seeing indefinitely, but it is a burden. It is going to take a lot of work. It is going to take a lot of treatment. And so as we look at diabetes, macular degeneration, hypertensive complications, these are all things that we're seeing increasing in prevalence. The number of patients that need our treatment to prevent blindness is only increasing as time goes on. And we haven't even really touched upon the societal impact of blindness. We are thankfully able to prevent that, but any one of those patients that go blind is now such a burden on society and can be very challenging for the family to assist. And these are patients that want to be in the workforce and be contributors to society. So the economic benefits there are tremendous at preventing blindness.
So, Dr. Dang, when something is this obvious and the data is this strong and supportive, why is it so difficult to impact change within our industry?
I think it has to do with the players who are making the decisions. And I'm really hopeful that policymakers are looking into prior authorization more specifically now. There's a lot of activity in Washington to hold insurance carriers responsible for their decisions on prior authorization. I think in the past there was a concern that providers may not be appropriately using medical resources. But as studies like this demonstrate, doctors want to take care of their patients and they overall do a good job. And I think this adds to the body of evidence that Washington can use to support their fight against insurance carriers overburdening providers, patients, and their caregivers with these administrative hassles.
So, Dr. Dang, excellent discussion. I appreciate that the ASRS has a major focus, and this is an incredibly supportive manuscript for the things that we have all been experiencing literally daily. So, thank you so much for joining us. Excellent discussion.
Happy to help. Thank you so much for having me join.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.